Welcome to episode 2 of the EyePros Podcast.
I'm Yasmine Abdalla.
I'm Ahmad Elsahn, and this is Know Your Consultant Part 2. Right. Yasmine, you've had such an incredible journey, yet most people don't actually understand the breadth of what you do, including some ophthalmologists. So just in short, tell us how you describe yourself to a patient.
So I'm a medical retina and uveitis specialist. So I was always medical retina by trade. So that is the part of the eye that is kind of like a film of the camera. So it processes all the information that comes through your part of the eye, the lens and the cornea. Without it, people are not able to process those images. And retinal diseases can be quite varied. Some of them are genetic. Diabetes can affect your retina. Also, age can affect your retina. And uveitis can affect your retina. So uveitis is inflammation in the eye, and it can affect your macula and your retina in different ways. It's presented in various ways. And having those 3 hats on, or 2 hats on, is quite important because I can actually differentiate between different conditions and treat them accordingly because there's such a big overlap.
Right, and I think you had also a very interesting journey as well. So we graduated from Alexandria University like me.
Yes.
And then we went to Wills
Eye
Hospital
Hospital,
as well.
absolutely,
Yes.
which was kind of a very transformative experience for me. You learned the basics of research. You walked amongst giants
Yes.
and legends. I still do attend their ocular oncology rounds every once a month on a Zoom meeting with the 𝗘𝘅𝗽𝗋𝗋𝗋 and the group.
Oh, that's a very, very important one, isn't it?
Because also with uveitis, you can have lots of masquerade. So keeping your ocular oncology buddies close by and learning about it is quite important to continue your
And
career.
ocular oncology is the tumors and cancers that can affect the eyes.
Absolutely. So a lot of them can masquerade in the form of uveitis. I also attend their medical retina rounds and its imaging rounds, which I find very important until this day.
Obviously, the tumors they're very, very rare, and that's the problem because they're so rare, you don't see them that much. You can miss them, but then you're attending those rounds to keep your knowledge.
Absolutely, and I keep my colleagues in Sheffield in the loop whenever I see something suspicious.
Yeah.
It is quite important to keep it in the back of your mind, but at the end of the day, you can't scare the patients too much because it is still rare.
Yeah, it's very rare. But it's reassuring to know that when you see something, you can spot or at least have that in the back of your mind.
Yes.
You're thinking about all the options.
Index of suspicion.
Is it genetic? Is it inflammatory? Is it just normal stuff? Is it just nothing?
Some common conditions that are self-limiting, and you would know I don't want this to be extra scientific, but can masquerade as inflammation. And if they're treated with steroids, they actually get worse.
Yeah.
So it's very good to have multiple hats on and to keep the differentials wide so that you're treating the correct thing at the correct time.
Great. So going back to your journey from the start, because this is very interesting. So after you finished your time in Philadelphia, you relocated to the UK, to Southampton. Mm-hmm. Tell us about that.
So I worked with Professor Andrew Lottery, which obviously...
world-renowned.
Absolutely. He's one of the biggest figures in retinal genetics. Working with him and his team actually ignited my passion for retina.
Yes.
So I've done a few years with him, and I've seen all sorts of genetic conditions that I wouldn't have seen in a standard medical retina fellowship or even training. So, and seeing all these conditions, and he used to quiz us in clinic and he would know that, really inspired me. In addition, it was, so obviously we had at the time 2 anti-VEGF or the injections for the macular degeneration, and we were introducing new ones. And we were also newer ones that were more kind of long-term, or they extend for about 2 months at the time. We have plenty now, more.
So you had this... So the genetics was also next to the other things like the macular degeneration, diabetics, all that. So it wasn't just that
Yes,
You know,
so
very
that was
specialized
Prof's
one.
niche, but I've also done lots of diabetic clinics and lots of macular degeneration clinics.
Yes.
I've done the first audit on 𝗘𝗏𝗶𝗁𝗹 introduction, which was the only longer acting anti-VEGF at the
Yes.
time. I've also witnessed the injection suite. So the injection suite was actually a very good idea to be able to inject many patients at once.
Yes.
So
Service development,
absolutely,
improving patient
absolutely,
journey.
because it was really quick, it was really slick, it only required one doctor
Yes.
and 4 HCAs, and
Yeah.
then you can have 4 patients in 4 different rooms, and you just go room to room.
Yeah, I worked in that. I remember we had this little competition about who is most efficient and
Yes, absolutely.
did more
And
patients
the
and helped more
patients
patients.
loved it, and it was very efficient. And patients themselves did not feel rushed, so that was the most important thing. But we were able to deliver the service to the numbers in a very efficient and safe way.
Yes.
Also, at the time, we didn't have the OCTA. It was quite a while ago, which is a new technology in scanning the eyes. Ocular computed tomography, but angiograph.
With angiography as well.
So this
you
is a
see
new
all the
technology.
blood vessels and
Correct.
what the problems
So
are.
historically, we used to give an injection. Well, we still do in some cases, a fluorescein injection, which is a dye that circulates in your body, and then we can see the circulation at the back of the eye. But at the time, it's still fairly invasive, not that dangerous, but still, we'd like to do something quick. So also at the time, I've audited conditions that you'd look at with just the Heidelberg OCT, which is non-invasive. It's a quick camera, and then which features that can point to which conditions, which was also a very exciting bit of research. And it did change my practice a bit, so not to become very dependent on more invasive procedures. Although I have to admit, I'm one of the very actually few consultants that order a lot of investigations, but that's because of my field and my
Because
interests.
obviously you look at genetics, you look at inflammation.
Absolutely.
But I mean, we're talking about something that's quite established now, the OCTA, and you were there right from the start, which just gives you this incredible perspective, doesn't it?
Uh-huh.
Great. And then I think you added uveitis to your toolkit.
Absolutely.
And, just for your listeners, what is uveitis and why is the combination of medical retina and uveitis so important? I mean, people would think, okay, these are 2 different specialties, but...
So I really do like uveitis. It is like solving a jigsaw puzzle. So uveitis basically is an inflammation in the middle layers of the eye. So that includes your iris, which is the colored part of the eye, your ciliary body, that's the structure that kind of produces the fluid in the front of the eye, which obviously you deal with as a glaucoma consultant.
Yeah. And that's our work overlaps there, doesn't
exactly.
it? Yeah.
And the choroid and the retina and the retinal vessels. So as I said before, the retina is the film of the camera, choroid is a vascular layer underneath that, and the retinal vessels. So all of this can be inflamed. And the challenge is to find out where the inflammation started and why did it start. Given 50% of the patients could be idiopathic, meaning there's no reason behind this, but sometimes you find very interesting reasons. So sometimes patients come with a diagnosis of an autoimmune condition. Sometimes, if you've got the right index of suspicion, you can diagnose an autoimmune condition or a genetic tendency, depending on how the patient presents. Sometimes it's an infection, some long-standing infection that the patient was not aware of and we need to treat. And sometimes it's even malignancy.
Yes, an autoimmune disease, just for our listeners, is when your body starts attacking its own tissue, doesn't it?
That's
correct. And it can be everywhere. So the uveitis can be a part of a whole?
A bigger condition. So rheumatoid arthritis,
yes.
Things like sarcoidosis, systemic lupus.
And that's incredible because you can help in treating those patients from those systemic conditions, just finding them in the eye.
Absolutely.
And can they start in the eye or can they find them, patients not aware of all these things?
Absolutely. A lot of my patients, I've made the diagnosis based on the eye, and then they were referred to respiratory physicians or rheumatoid physicians for further treatment. And I do liaise with all these physicians, and I have MDTs with them, which is multidisciplinary team meetings, to and lots of gastrointestinal conditions as well, like Crohn's and ulcerative colitis. So
you're good for the health. basically for everything.
I would say so. I'm good for your health. So basically my gastroenterology colleagues, my rheumatology colleagues, my respiratory colleagues, my infectious disease colleagues, gum colleagues, genitourinary health colleagues, all these colleagues I do meet with regularly. And when we have common patients, we try and decide on which medication is the best for everything. So I would, if for instance I've got a patient with known sarcoidosis, I would talk to my respiratory colleagues and say, if I want to immune suppress that patient, what will work for you as much as it would work for me? And both of us would decide on the treatment.
That's great.
Yeah.
But you still do the other stuff, the bread and butter, like macular degeneration.
I actually quite enjoy it.
Yes, it's I mean, that's quite a diverse scope of practice. So something like diabetic eye disease, this is the preventable, I think this is the number one preventable cause of preventable blindness in working age population. Massive numbers. Tell us about that. How do you deal with that?
So in the UK, there is a screening program, annual screening program for anyone with diabetes.
Yes, I'm familiar with that.
They have to go and have their photographs taken. What happens is there are national criteria for referral to hospital eye services.
Yes.
Diabetes is a vascular disease, meaning it affects your blood vessels.
Oh, so it can affect anything, anywhere in the body as well?
Absolutely. It can affect your kidneys, it can affect your nerve endings, and it can affect your eyes.
Mm-hmm.
It can affect your eyes, the bit that I know about, in two ways. So the leakage in the blood vessels and the lack of oxygen can cause new vessels that can grow and bleed and cause retinal detachments.
I'm well aware of that. It can cause glaucoma as well.
And it can cause glaucoma.
And we treat it by liaising with you. So I have those. We treat them by treating the cause.
Absolutely.
It's not just a glaucoma.
So we can treat that with lasers, panretinal photocoagulation. It also can cause swelling in the middle part of the retina, and then that would affect the patient's vision and reading. Unfortunately, the proliferation of blood vessels is usually asymptomatic until it's quite late. The swelling, patients tend to come saying, my central vision is affected, I can't read, lines are blurry, lines are wiggly or wobbly. When that happens, obviously the treatment becomes either, depending on where the swelling is and the amount of swelling, we treat with anti-VEGF injections, which are injections in the eye.
Yes.
Same injections we use for macular degeneration, with addition to also steroid injections that we might add on for diabetics.
That sounds scary. Patients would be like, oh, I'm getting an injection in the eye.
I am yet to encounter a patient who would look forward to an injection in the eye as an idea. But once they have it, it's not that painful. They're thoroughly numb, and all they feel is a bit of pressure. It takes about 2 seconds to happen, but the idea is really scary. I do agree. And I do think our patients are very brave, because they're actually handing their eyes to us to inject, and that is a privilege.
Yes.
But once they see how much improvement they get with the injections, they actually want it. We don't have any patients who do not want to attend their injections once they've got demonstrable improvement.
Yes.
So yes, I agree with you. It's a scary thought, but as a matter of fact, for all our listeners out there, it's not scary.
And it maintains, they can drive, they can do the things they love, they can play golf, they can see their loved ones, they play with the grandchildren. There's just so many. And keep their job. And
right now, with the more longer acting agents, we can extend the periods between injections to up to 12 weeks and sometimes more. So it's not basically the injection burden is much less.
Yes.
There are also steroids that we can add to our diabetics that can last 6 months to 3 years, depending on the type of steroid.
Yes.
So I think with all the treatments that we've got now, it is not that pressurized as it used to be, where I remember I was there in the PRN ages, which is as needed injections, where patients came every month for a scan and an injection. Yeah. It's not that way anymore. It's much easier, I believe.
Well, that's great. And the injections will take us to the next big one, which is age-related macular degeneration. And that's a massive one as well, and it's a big burden. Tell us about that. Tell us about your practice.
Obviously, we are an aging population in the UK. So part of aging is having age-related macular degeneration.
Just like cataract?
Just like cataract. Unfortunately, there's not a quick fix like cataract for it. So we've got two types. We'd say for the purpose of this podcast, a dry type and a wet type. So what happens with the dry type, it's just the layer of your retina that's responsible for the metabolism is not working as well as it used to.
Yeah. Like has wear and tear changes, and it just doesn't work as well.
Absolutely. And then after a while, you start getting areas of thinning. Think of it as an old drug with thinned areas.
Right.
So when that happens, unfortunately in the UK currently, in the NHS, we don't have any treatment for that.
Yeah.
There are some injectable treatments coming up in the US, and there's photobiomodulation treatment in the UK for that, but it's not available on the NHS, only in private providers.
But it is available in private, is it?
It is available in private providers, and the idea behind photobiomodulation, it basically slows down the progress of those thinning areas,
right,
so that you preserve your vision for as long as possible.
But it can help patients sometimes even gain some letter.
You can. So the preliminary studies said that there is some number of letters gain as well.
Okay. It's better than nothing.
Option. Exactly. Yeah. So unfortunately, currently with our NHS patients, we give them advice, self-monitoring, and basically if they turn into the wet type, which is basically a small membrane that leaks fluid under the retina, then we go ahead and get them injection treatments. But as long as they're the dry type, there is no treatment to be offered on the NHS at this point of time. But fingers crossed, maybe in the future.
Yeah, but photobiomodulation would help patients at least have something.
At least. So if we think of it, it puts the brakes on the progression. That's the least we can hope for.
Yes.
So if I am to progress in 2 years' time and lose 2 lines, if I keep what I've got now or even gain a little bit, then I'm winning.
That's great. Especially if you start with a good vision already, functioning vision already.
Absolutely.
Okay, and then the wet type.
So the wet type, it's still injections. We've got plenty injections now.
Is it similar to the diabetic eye disease one?
It's exactly the same. And we've got multiple anti-VEGF agents now with multiple kind of modes of action and longevity as well.
Great. And that helps patients also maintain the vision and improves in many patients, doesn't it?
Absolutely.
But that's available in the NHS.
It's available on the NHS.
Great.
So unless you just want a bit of TLC or you want a specific agent that your hospital is not offering, then that might be like a little scope for you to go privately for that.
Right.
But injections in general are offered in the NHS.
So you're specializing in the back of the eye, but there's so many things you look after. The diabetic eye disease, macular degeneration, there are other problems, and also the uveitis. How does all of this come into practice? You said about oncology and
so a lot of things, as I said. So some diabetics can have uveitis, and I had a referral once, and the patient, all they had is just some diabetic retinopathy in addition to anterior uveitis, which is in the front of the eye. But it was mistaken for posterior uveitis or pan-uveitis because they thought the retinopathy
was because of the inflammation.
Secondary to the inflammation.
Right.
Well, if you just do the patient's, blood sugar test, it was roaring high, and the distribution of the vasculopathy, if you will, or the vascular change, was very kind of in keeping with diabetes. And I think that's where it comes, this kind of breadth of knowledge.
So it's not under-treating only, it's also preventing over-treating.
Exactly. And for instance, people with multifocal central serous retinopathy, again, not to bore people, that this is a condition secondary to steroid use or stress.
And you've also been involved in professional leadership. So ever since you're a trainee, you were part of the ophthalmic training group, you were a member of the examination committee, and then you are now an examiner for the Royal College of Ophthalmologists, and you're the college tutor for training doctors as well. And that's a nice diverse part of your practice.
That's right. So I always had passion for training. As a trainee, I really believed in the system. Actually, I'm very passionate about the NHS and the training programs we've got, and I'm really proud of them. So as a trainee, I wanted to be the voice of the trainees, to voice their concerns, and to be a stakeholder in the decisions made by the college. Being part of the ophthalmic training group, we had roles in everything. College related, professional committee, examination committee, we even equality and diversity. The GMC at the time was wanting to change the curriculum. And at the time, I have attended a lot of meetings with the GMC about curriculum changes.
Yes. And I remember as a trainee, because we both trained in the same region, you would come to us and asked us about our opinion, then convey that to the committees.
Absolutely. So, and every, we used to take minutes and write like a synopsis and feedback to the trainees. Being part of the examination committee was actually very interesting because I could see how the profession benchmarks the not only knowledge and skills and clinical acumen, but also ethics of who to acquire the FRC certificate and who becomes the member of this establishment. So it was quite eye-opening, and it really helped me also as an examiner now to understand how to design an exam question and how to ask people and how to assess them in a fair manner.
And does that affect your clinical practice?
Of course, because actually it can reflect quite a bit on clinical practice because I want to hold myself to the same standard I hold others at. Being the college tutor as well is quite important part of my role, because as a trainee, I advocated for the trainee, and as a college tutor, I actually advocate even more for the trainees because I create the timetables. And at the pressures we've got now with service, it's very difficult to maintain a good quality training program and provide the service and care for the big number of patients coming through the doors. So they're trying times, but I try to do my best to give the best chance for my trainees to have a great training experience while caring for the patients.
So last question on this section. I know that you published a lot. We have shared research history together, but you've also published on a few other important topics. Tell us about something that affects your practice now, you're very passionate about.
So actually, I'm quite proud. I'm actually working on a couple of publications that are still kind of in submission right now with one of my trainees. However, the one thing that I'm really passionate about was the BEST's novel presenting phenotype.
So BEST is a
genetic condition.
So, okay, BEST is a name of a person, not a description of something.
No, it's a genetic condition.
Yes.
That I've described a novel phenotype, which is a novel presentation in a little girl.
Okay. So she looked different than other people usually with this condition?
Yes, but she's got genetically proven condition. However, the way it presented was very different, and it's different from the new kind of, so usually this condition is autosomal dominant, meaning it runs through families, through all generations. There is a different type of it that's recessive, which is a hidden type, but hers was actually the dominant gene, and yet she presented in an odd manner, not similar to either types.
Right.
So it was quite interesting.
That's very interesting, and this is also, again, it kind of helps inform your practice, because if you know the not unusual ones, then you're very kind of comfortable with the usual ones and how to treat them.
Genetics is quite important. I do work closely with my genetic colleagues in Nottingham because they not only change the patient's life and expectancy of what's going to happen. So even if we can't treat them, or if there isn't currently a trial going on for that specific condition, but it's good to have the genetic diagnosis because it informs your future, it informs your family planning. So you really can't miss them because it can really affect the patients, and some of them are quite young. So you really need to know so that you can inform the patient and sometimes the parents about how the future would look like.
Right. So you have such a diverse practice, Yasmine, and I'm very happy and excited that we work together, because now I don't have to worry about anything behind the lens. So I deal with everything in the front, obviously the optic nerve, but then I know that I can trust you in the back of the eye. And thanks for sharing your incredible journey with us.
Thank you. I hope our listeners enjoyed it as well.
Thank you for watching and listening. In the next episode, we'll talk about how we came together and how EyePros came to existence. So stay tuned.